very warm welcome to all the delegates. At the outset, I would like to thank the scientific committee and the organizing committee of the Drishti 2025 for providing us with this opportunity. So our instruction course is Unravelling Neurophthalmic Enigmas. So by this instruction course, we are planning to outline some challenging cases where history taking is important and we should not miss subtle signs of neuroophthalmology. So this would help general ophthalmologists also. And the course, we have 6 talks, and at the end we have a keynote address by an eminent radiologist, Dr. Bijoy Thomas from Sri Chitra Institute of Medical Sciences. So I would like to first invite Dr. Papa Padmavati, Professor R.I.U. Trivandrum, for her talk on red flags we should not miss in neuroophthalmology. Welcome, Dr. Papa.
Thank you, Bindu, for giving me this chance. So I'll be dealing with some of the warning signals in a case of neuroophthalmology. Symptom-wise, it is mainly double vision. The patient complains of double vision. You should suspect. And if there is an unexplained visual loss or a headache with defective vision without any ocular cause, or a patient complains of visual field defect like this, a bitemporal defect or visual hallucinations, all these point to a neuroophthalmic case. Diplopia, it should be binocular in a case of neuroophthalmology, and there can be variations with gaze. If it is a nerve palsy, and tilted image indicates a superior oblique palsy. Recent head trauma is important. Diurnal variations are common in myopathies like myasthenia. Associated pain if a nerve is involved, and systemic diseases like diabetes, hypertension that can produce ischemic nerve palsies. Headache, the location of headache is important if it is on the orbit or in the sinuses, and if there is the diurnal variations and postural variations are seen common with patients with increased ICT. The severity of headache is also important. If it is a constant headache, maybe a tumor. If it is an acute severe headache, it may be a vascular or inflammatory lesion. Defective vision, usually in neuroophthalmic cases, it is bilateral. If it is progressive defective vision, it can be a tumor. If there is associated vomiting, seizure, fever, all these indicate increased ICT. Visual hallucinations are seen in temporal lobe lesions. And on examination, if the patient has a ptosis, a unilateral ptosis with divergent squint, plus or minus an abnormal pupil, it is a third nerve palsy. There is bilateral ptosis, diurnal variations, and fatigue phenomenon. It indicates points to an ocular myasthenia. It is unilateral mild ptosis, small pupil, heterochromia. It's in favor of Horner syndrome. It dilates with apraclonidine or phenylephrine. Amphetamine can be used to differentiate a preganglionic lesion from postganglionic. Visual field defects are an important part of any neuroophthalmic case. It shows different patterns. It respects the vertical midline. It can be bitemporal, binasal, or homonymous hemianopias or quadrant anopias with macula sparing and all. That depends on the site of this lesion. Recent onset squint, usually concomitant, indicates a nerve palsy. Here you can see a left sixth nerve palsy, and this sixth nerve palsy is also a false localizing sign. Nystagmus, there can be downbeat nystagmus, which can be seen in Arnold-Chiari malformation or posterior fossa tumors, or there can be Ksos nystagmus in case of cellular tumors, or there can be ataxic nystagmus of the abducting eye in a case of internuclear ophthalmoplegia. So all these point to the diagnosis. Pupil, the key player in any neuroophthalmic case. Here you can see the right eye, the direct light reflex is not reacting much. So it's a relative afferent pupillary defect. It's indicative of optic nerve lesions and intracranial space occupying lesions. Anisocoria is one important sign, unequal pupil size. So if you put the patient in the dim light and if it increases, if anisocoria increases means it can be physiological or it can be Horner syndrome or with posterior synechia. If the anisocoria increases in light means the large pupil is at fault. It can be third nerve palsy or Addy's pupil or traumatic mydriasis or even pharmacological mydriasis. Next is the light near dissociation. Here you can see there is no reaction to the light, but the child reacts to the near reflex. So this is usually seen in Addy's pupil, Argyll-Robertson pupil, and dorsal midbrain syndromes. And these people, usually the short ciliary nerves are at fault and shows light near dissociation, and there is denervation supersensitivity to 0.1% pilocarpine, and you can see the vermiform movements of the pupil. Argyll Robertson typically seen in neurosyphilis. It can be seen in diabetic patients, alcoholics, and it shows the light near dissociation. Dorsal midbrain lesions, it is a triad actually. It's an upgaze palsy due to double elevator palsy, convergence retraction nystagmus, and light near dissociation. Here it is mainly due to the dorsal midbrain lesions like pineal gland tumors. Proptosis. If a proptosis is associated with defective vision, it is important. You can see the optic nerve sheath meningioma, or if the proptosis is pulsatile, and if it is painful, and if it is associated with defective vision, all these things are important in a neurophthalmic case. A patient presenting like an orbital inflammatory disease, this may be a Tolosa Hunt. You can mistake it for a pseudotumor or a mucormycosis because Tolosa also comes in diabetic patients. Other red flags that we should not miss include optociliary shunt vessels. It is usually seen in optic nerve sheath meningiomas, or a disc edema. It's a bilateral disc edema, points to an increased ICT, or a temporal pallor which indicates any compression of the afferent pathway, the optic nerve and the visual tracts. And sometimes a red eye which is not responding to any treatment. When you closely examine, you can see the corkscrewing of the conjunctival vessels, which is usually seen in a case of caroticocavernous fistula. So these are the points I just want to highlight. Thank you for the patient here.
Thank you, Dr. Papa, for that crisp presentation. Let me invite the next speaker, Dr. Remya Raghavan, Professor, Sri Gokulam Medical College, for her next talk, Looking Beyond the Typical Unusual Presentations of Optic Neuritis. Over to you.
Good morning, all. My topic is looking beyond the typical. So let us go through two unusual cases of optic neuritis. The first case is about a 51-year-old female who came with sudden loss of vision in both eyes, and that was associated with pain. And on examination, the best corrected visual acuity in the right eye was perception of light, and in the left eye it was 2/60. Color vision was defective in left eye, and pupils were both dilated and reacting sluggishly to light in both eyes. And fundus showed bilateral optic disc edema associated with hyperemia. So we made a diagnosis of optic neuritis both eyes. She underwent a lot of investigations in the Department of Neurology, including CSF study, serum ACE level, NMO emoji antibodies, paraneoplastic panel, everything was known. MRI brain and orbit showed bilateral, bulky appearing optic nerves with T2 hyperintensity and mild contrast enhancement, suggestive of optic neuritis both eyes. But SCL70 and PMSCL were positive in ANA profile. So these two were the positive reports. So she was put on IV methylprednisolone and then tapering oral prednisolone, and her vision partially improved following this. But after 5 months, she came with a relapse in the right eye with a visual acuity of 2/60, and again another relapse after 8 months in the same eye with a visual acuity of 6/60. So now on examination, the fundus showed bilateral optic disc pallor and arteriolar attenuation. The OCT, you can see that there is superior inferior peripapillary RNFL thinning in the right eye and mild focal RNFL thinning in the infratemporal quadrant, the left eye. MRI brain and orbit showed mild hyperintensity in bilateral optic nerves, BEP prolongation and decreased amplitude. Then repeat NMO and emoji antibodies were negative. The positive result was AMA M2, which was highly positive. She was again put on IV methylprednisolone, and during the follow-up period, her visual acuity became 6/18 in both eyes. So this condition is called chronic relapsing inflammatory optic neuropathy. So this is characterized by its steroid responsiveness as well as its relapsing and or chronic duration. So how do you diagnose this? So there should be a history of optic neuritis with at least one relapse and objective evidence of loss of visual function. Neuromyelitis optica IgG should be negative, and the MRI should show contrast enhancement of acutely inflamed optic nerves. And there will be a response to immunosuppressive treatment and relapse or withdrawal or dose reduction of steroid. So how do you differentiate it from atypical optic neuritis? This is crayon is actually a subtype of atypical optic neuritis, and it is characterized by its relapsing chronic course and high sensitivity to steroid. But the thing is, if you reduce the dose or withdraw the steroid, then there will be a relapse. And aquaporin P4 and emoji antibodies will be negative. So the take-home message is this condition crayon is essentially a disease of exclusion, and it is very difficult to differentiate it from multiple sclerosis, NMO spectrum of disorders, and MOGAD. And patients, though they typically respond to steroids initially, the relapses are common upon withdrawal, and cumulative damage to the optic nerve will be there due to frequent relapses. And some patients, they come with multiple episodes which are refractory to conventional treatment. So they may require more advanced treatment. The second case here, this is about an 11-year-old girl who came with sudden loss of vision associated with pain in the right eye. And on examination, the visual acuity was reduced in that eye, and the optic nerve functions were all defective in that eye. And fundus showed optic disc edema with hyperemia, and you can see the OCT with peripapillary RNFL thickening. And so we made a diagnosis of optic neuritis right eye for that girl, and MRI brain and orbit showed features of optic neuritis. Flash VEP also showed features of optic neuritis. And we looked for the antibody profile. Anti-aquaporin 4 and NMO IgG were negative, but we got a positive result, that is anti-myelin oligodendrocyte glycoprotein antibody, that is IgG, was strongly positive. So she was put on IV methylprednisolone, followed by oral prednisolone, and after 5 days treatment, the visual acuity became 6/6. Now, this child came with another relapse at 8 months. So here, now the left eye was affected, there was defective vision in the left eye, and the optic nerve functions were affected. And the fundus showed optic disc edema with hyperemia, and OCT also showed thickening of peripapillary RNFL. MRA showed thickening of the optic nerve in the left eye, and again she was treated with steroids. And after 1 month, you can see temporal pallor of the optics in the right eye, and left eye looks normal. OCT showed focal peripapillary RNFL thinning in the right eye superiorly, and normal OCT in the left eye. So this condition is called MOGAD-associated optic neuritis. So what is it? So MOGAD is myelin oligodendrocyte glycoprotein antibody-associated disease. So this is an inflammatory disease of the CNS which is characterized by immune-mediated demyelination involving the brain, spinal cord, and optic nerves. So this is common below 18 years of age, and there is no sex predilection. And actually, MOGAD accounts for nearly 50% of acute demyelinating syndromes in children. But the most common manifestation of MOGAD is acute disseminated encephalomyelitis, and the second most common manifestation is optic neuritis. And optic neuritis is mostly it is bilateral and simultaneously bilateral in about 31 to 84%. And most of the patients, they present with another attack of optic neuritis during the follow-up period. And the disease-modifying agents which are usually used for treatment of multiple sclerosis may not be that effective in this condition. So the take-home message is, unlike MS, the incidence of MOGAD is higher in children, and the most common manifestation of MOGAD is acute disseminated encephalomyelitis, and long-term follow-up and monitoring is needed for potential relapses. Thank you.
Thank you, Dr. Ramya, for that excellent presentation. We'll take up the discussions on the topics at the end of the session. So let me invite the next speaker, Dr. Naina Haidar, for her talk, To Move or Not to Move, Abnormal Ocular Motility Decoded. Over to you, madam.
At the outset, I'd like to thank the Gokulam team for giving me the opportunity to present this topic. Just the previous speaker has showed you some pictures of the extraocular movements, especially the nuclear, that is the nerve palsies. I will be touching more over the supranuclear palsies. So this was a patient who had come to RIO, referred from the neuromedicine side, and she was a 50-year-old female patient, and she complained of diplopia. And usually on the lateral sides she complained, and I will come to that. And so just just to catch up for the PGs, the medial longitudinal fasciculus. It is a myelinated nerve tract connecting the third nerve nucleus and on the ipsilateral side in the midbrain with the PPRF and the sixth nerve on the contralateral side in the pons. So we have an MLF which is connecting the midbrain and pons. It is located ventral to the aqueduct in the midbrain and it lies near the midline. So this is the most, I think, familiar picture we have seen in our anatomy books. And you can see the MLF which is in red and connecting the third nerve in the midbrain and the sixth nerve in the pons, and it is associated with the PPRF, closely aligned with the sixth nerve. So the INO symptoms, this lady came with diplopia, not in the primary gaze, but more in the lateral gazes, and there is in INO you have this difficulty in tracking the high speed object. So in a neuroophthalmic case, you should be checking the saccades and the pursuits, and in addition to your extraocular movements, and there is history of headache. So you have to do a good extraocular assessment, and in INO you do get a ipsilateral adduction deficit with a contralateral abducting nystagmus and decreased horizontal saccades velocity. So there's a close-up picture, and you can see the abducting nystagmus in the right side, and you can see a -1 little bit of abduction. Also, this is actually a bilateral INO. So you can see the abducting nystagmus in the right eye, whereas the left eye you see a -1 convergence or a adduction which is deficit. So this lady present with bilateral INO. So there's one condition known as INO plus. So to add on more to the confusion, you have a hypertropic skew deviation on the same side and the abnormal OKN nystagmus pursuits. There is a vertical gaze evoked nystagmus on an up gaze, abnormal vestibulo-ocular. So in a INO, you might have these combinations, and you have a pseudo INO, which is there in myasthenia and in Guillain-Barré syndrome. And the convergence may be normal or absent. So we have an anterior INO that is in the region of the midbrain. There will be an absence of convergence, whereas in a posterior INO, which is most related to the pons, the normal convergence would be there. And you are more familiar with Webino, that is a bilateral INO, where you have a primary position exo and a bilateral adduction deficit with bilateral abduction nystagmus. And there is also Vemino, so it's a monoocular INO with primary position exotropia. So as I said, the MLF and the PPRF, it can also be involved, and that you get is a 1.5 syndrome. So in that condition, there will be no horizontal movement. The ipsilateral eye, you can see on the picture on the left side, when the patient is moving on to the left side, the left eye is not moving at all. So you have, that is, the contralateral adduction is affected with the preserved abduction and an abducting nystagmus. I don't have a video in this. And etiology coming to INO is demyelination. I think the Dr. Bijoy would be showing us interesting films of this. And for this patient, we had this, as I said, the female patient had a meningoencephalitis, and she gave us this condition, and it was managed by the neurology people. And when she came back, she was normal, and the INO had disappeared. So demyelination, ischemia, infections, Arnold-Chiari, the inflammatory trauma, and neoplasms. So another condition is Perinal syndrome. We have different names. I think for the PGs it'll be confusing and interesting. Dorsal midbrain, Sylvian aqueduct syndrome, presectactyl syndromes. And you have here is the vertical gaze center which is affected. And in this condition, you have an upward gaze palsy and a convergent retraction nystagmus, which is seen in this patient, who also came from the neurology, neurosurgical department. And actually, I'm telling the patient to look up, and he doesn't seem to look up. You get this very interesting, the convergent retraction nystagmus, and the down gaze is normal. And so this patient was a 55-year-old. Again, I'm asking the patient to look up. He's not able to look up, and the convergent distraction nystagmus is so beautifully seen, and that gives you a diagnosis of a Perinaut syndrome. And the etiology is the peniloma. This patient presented with peniloma, and you can have Perinauts in hydrocephalus trauma. So another patient is progressive supranuclear palsy, and you have Parkinsonism like features which make the patient inability to have a down gaze. So the patient has difficulty in reading, and he's not able to climb the steps. So these are the usual, that is the INO, the Parinauds, and the progressive supranuclear palsies which can come to you, and these are the normal. So the saccades and the pursuits have been assessed in every patient with neurological and neurophthalmic signs, and you have to take time to see these patients patiently. The extra motility, extraocular movements have to be assessed, and abnormal ocular movements may be confusing and challenging, but a thorough extraocular assessment can be done, and which can be can be interesting in a way. Thank you.
Thank you, Naina Madam, for that wonderful talk. So you explained those complex topics with so much clarity. Thank you. May I invite Dr. Bindu Thambi, Professor, Department of Ophthalmology, Gogulam Medical College, for her talk on a curious case of droopy eyes in a toddler.
Good morning, all. So I would be presenting a curious case of droopy eyes in a toddler before you. A child, 1 year, 9-month-old child, presented with drooping of both upper eyelids, noticed by the parents 1 month back. There were no other associated symptoms like fever, seizures, headache. So a previous photograph, that is around 3 months back, was normal. So on probing further, the parents told that there was worsening of the ptosis towards evening, improvement after rest, but the birth and family history were unremarkable. The child had an chin elevated posture with bilateral upper lid ptosis. The ocular movements were full. So for a ptosis in toddler, we considered a myogenic cause, a neuromuscular junction disorder, neurogenic cause, any associated syndromes, or an acquired cause. In myogenic cause, there would be no fluctuation in ptosis, and neurogenic causes, there would be ophthalmoplegia or meiosis, and there were no features of any syndromes. So we narrowed down our diagnosis to neuromuscular junction disorder, that is juvenile myasthenia gravis or a congenital myasthenia, as the ptosis was fluctuating and fatigable. So we did an ice pack test, which turned out to be positive. There was significant improvement in ptosis. So we referred the child for a neurology evaluation, and there the parents revealed history of frequent falls, drooling of saliva, occasional difficulty in swallowing, decreased facial expressions, all in the past 2 weeks. But there was no history of shortness of breath. Child was active and alert. The central nervous system was normal except for the bilateral ptosis. Gag reflex was present, and palatal movements were also equal. So a neostigmine challenge test was done. Neostigmine 0.4 milligram was given IM with all due precautions in a pediatric ICU, which turned out to be positive. That is, there was remarkable improvement in ptosis. The child had expressions in the face. The nasolabial fold was there. So other investigations like blood investigations were normal. There was no thymoma on imaging. But on doing serology, the anti-acetylcholine receptor antibody and the anti-muscarinic kinase, anti-muscle specific kinase antibody was negative. So that led to a diagnostic dilemma whether it is a double seronegative myasthenia gravis. So in myasthenia gravis, 70 to 80% show a positive serology, or a congenital myasthenic syndrome. So we shall see about childhood myasthenia. It comprises around 10 to 15% of myasthenia cases. It could be transient neonatal myasthenia, juvenile myasthenia gravis, or a congenital myasthenic syndrome. Transient neonatal myasthenia occurs due to transplacental diffusion of autoantibodies from a myasthenic mother. So we ruled out that, and we were left with the other 2 options. So we shall see what they are. The juvenile myasthenia is an autoimmune disorder of the neuromuscular transmission, where there is production of antibodies against components of the postsynaptic membrane of the neuromuscular junction, and they target the acetylcholine receptor and muscle-specific kinase. So in generalized myasthenia, around 70 to 80% show anti-acetylcholine receptor antibodies, and in ocular myasthenia it is 50%, whereas only 5 to 8% of myasthenia reveal MuSK antibodies. Purely ocular myasthenia may be seronegative in 50%, and it is 15% in generalized myasthenia. So double seronegative myasthenia gravis is an entity where the patient is negative for both the antibodies, but the clinical presentation is similar to myasthenia with acetylcholine receptor antibodies in terms of muscle weakness, distribution, disease severity, response to immunotherapy, and plasma exchange. So treatment options are pyridostigmine, immunosuppressive therapy, intravenous immunoglobulin, plasma exchange, and thymectomy, very rarely done in children in selected cases. So on the other hand, congenital myasthenic syndrome is a genetic condition. There is a mutation in genes that code for proteins. There is abnormality of the proteins involved in the neuromuscular transmission. So this also present with fatigable weakness and maybe ocular or generalized symptoms. But there is a positive family history, and muscle biopsy can show tubular aggregates. So genetic testing is crucial in the diagnosis. So here pyridostigmine may not be effective in all subtypes, and the definitive treatment is gene therapy with antisense oligonucleotides. So challenges we faced because of the patient being a toddler was that autoimmune myasthenia is very rare in toddler age group, whereas congenital myasthenia is seen in neonates to 8 years. But there may be overlap in symptoms, that is both present with fatigable weakness, doses, fluctuating doses, and moreover the antibody was negative in our patient. So genetic testing became crucial for the diagnosis. So we can differentiate the two by a positive, good response to pyridostigmine and immunosuppressives in juvenile myasthenia, whereas the response will be poor in congenital myasthenia, and there will be a positive family history. So for our child, we started pyridostigmine and along with oral steroids, and there was significant improvement. And later on, we did a genetic testing which turned negative, and repeat antibody testing was advised after 6 months. So any child with myasthenic symptoms, after doing all the necessary investigations, serology has to be done. If it is seropositive, there is no doubt in diagnosis, it is juvenile myasthenia. But when it is seronegative, there is a doubt whether it is a double seronegative myasthenia or a congenital myasthenia. So we have to differentiate between the two, as the treatment options are different. And if the diagnosis of myasthenia is missed, child can go on to generalized myasthenia and have respiratory complications which can be life-threatening. Thank you.
Thank you, Bindu Madam, for that wonderful talk. May I invite Dr. Rekha R.S., Associated Professor, Gokhale Medical College, for a talk on the pulsating puzzle, a danger at the crossroads.
Can I have the pointer? So good morning. So my talk is on the pulsating puzzle, danger at the crossroads. So this is a challenging case with a twist at the end. So my patient was a 28-year-old CRPF Jawan who presented with redness of the right eye of 10 days duration. He was being treated as conjunctivitis at multiple places. He gave a history of RTA 2 months ago with head injury and multiple skull bone fractures, but at that time there was no ocular related injuries. On examination, he had all the visual parameters were all within normal limits with 6/6 vision, except for a mild periorbital fullness and a 3 mm axial mildly pulsatile proptosis on the right side, which is evident on the by the Navziger's method on the right hand side. On examination, you can see the dilated and tortuous episcleral vessels, which is called the arterialization of the episcleral veins throughout. The intraocular pressures, fundus, everything was within normal limits. There was no bruit, but on inquiry, he said he could hear a mild whooshing sound in the head. So, provisional diagnosis of right traumatic carotid-cavernous fistula with pulsatile proptosis was made. So, what's a carotid-cavernous fistula? As you all know, it's an abnormal communication between the carotid artery, usually the internal carotid artery, and the cavernous sinus. So here you can see the cavernous sinus is the intracavernous segment of the internal carotid artery. You can also see the superior ophthalmic vein and the inferior ophthalmic veins draining into the cavernous sinus. So here what happens is that when there is a communication between an artery and a vein, the low pressure venous system now becomes a high pressure system, so that there is dilatation of the draining veins and venous congestion in the drainage areas. So there are different classifications. Barrett's classification is the most accepted, where type A is called the direct fistula, where there is direct communication of the internal carotid artery into the cavernous sinus. In all the other types, which are called the indirect fistulas, the communication is with one of the meningeal branches of either the internal carotid artery or the external carotid artery, or both with the cavernous sinus. So etiologically it can be traumatic, which is usually high flow, occurs in young males after an RTA usually, or low flow spontaneous, which are usually low flow fistulas, where there be pre-existing arterial weakness, common in elderly hypertensive females, or arterial aneurysms or other syndromes where there can be arterial weakness. So we did a CT angiogram for this picture. We can see on the right hand side there is a huge dilatation of the right cavernous sinus with all the engorgement of all the dilating tributaries, and also you can see the hugely engorged superior ophthalmic vein and the inferior ophthalmic vein. So our patient was a case of direct CCF, and he was advised to do the gold standard of investigation in this case, that is a digital subtraction angiography. So what is it? In DSA, what we do is a catheter is introduced into an artery, into the vessel, and a dye is injected and serial X-rays are taken. And all the other masking structures like the bones and the soft tissues are digitally subtracted, so that we get a high resolution image of the vessels. But due to financial constraints, the patient did not turn up. But 1 month later, he presented with diminution of vision of the eye, with increase in redness. At that time, the vision had dropped to 6/12 and the intraocular pressure had increased to 24 millimeters of mercury. And the fundus showed temporal disc pallor, which was evidence of optic disc ischemia and dilated and tortuous veins due to the venous congestion, and the optic disc ischemia was confirmed by the opacity of the optic disc. So now it has become a direct CCF with pulsatile proptosis, secondary glaucoma and optic disc ischemia. So now it was a vision threatening condition. So at this time he agreed to do the DSA. So while doing the digital suppression angiography, not only there was immediate leakage of dye into the cavernous sinus, this was something interesting called the steel phenomenon. So this was the crossroads I was talking about. So you know the circle of Willis. It is formed anteriorly by the internal carotid artery. That is, after emerging from the cavernous sinus, the internal carotid artery gives off the anterior cerebral artery, which communicates with the opposite side through the anterior communicating artery. Then it continues as the middle cerebral artery. Posteriorly, it is formed by the two vertebral arteries, which gives off the posterior cerebral artery, which communicates with the MCA through the posterior communicating artery. So in a crossroad, you know, you can go in any direction. The same thing happened here. So what happened here was, as soon as the blood was entering into the internal carotid artery, the blood was leaking immediately into the cavernous sinus. So there was no blood to supply the right ACA and the right MCA. So what happened was that the right ACA was actually stealing blood from the left ACA through the anterior communicating artery, and the right MCA was stealing blood from the posterior circulation through the posterior communicating artery. So this was evident on doing the DSA. So on the left hand side, this is the DSA done with the catheter on the right internal carotid artery. You can see that as soon as it enters into the right internal carotid artery, it was leaking out. There was no filling on the right hand side, there is no filling of the right ACA or the MCA. But at the same time, when the DSA was done with the catheter in the left internal carotid artery, you can see there is not only filling on the left ACA, there is also filling of the right ACA through the anterior communicating artery. So the right side was stealing blood from the left side. Then again the DSA was done with the catheter in the left vertebral artery. This is the left vertebral artery. And you can see not only there is filling on the left hand side, more than that the blood was actually flowing more to the right hand side. That is, through the left vertebral artery there is filling of both the posterior cerebral arteries, and then through the posterior communicating artery the right MCA was stealing blood. So here you can see the entire right half of the brain was stealing blood from the left half of the brain more than the left side. So there was vascular compromise to the left half of the brain. This could have led to an ischemic stroke on the left side. But luckily our patient did not develop any neurologic signs. So that now not only is it vision threatening, it has now become life threatening also. So we took up the patient for emergency management. So the gold standard of management here is endovascular embolization and coiling of the carotid cavernous fistula. So the right internal carotid artery was accessed through the right femoral artery, and multiple coils were used to seal the defects in the internal carotid artery. And these are the embolizing agents used. That's the dimethyl sulfoxide and squid-18, and all the fistula was sealed. And then the DSA was again repeated through the right internal carotid artery, and this time you can see there is beautiful filling of the right ACA and the right NCA. Okay. So you can compare the pre-procedure DSA. This is the pre-procedure, there was no filling on the right hand side, and post-procedure there was immediate filling of the right hand side. And what we noticed was that clinically also, immediately on the post-op day 1 itself, every ocular parameters came back to normal. The eye became quiet, the edema disappeared, the visual acuity came back to 6/6, intraocular pressure came back to normal. So the take-home message is that a high suspicion of CCF should be there when a patient presents with retinitis and proptosis after a head injury. The DSA is the gold standard for diagnosis. Steal phenomenon should be suspected if it is a large CCF, especially if other neurological symptoms develop. And endovascular coiling and embolization is the most preferred treatment. Thank you.
After that excellent case-based discussion on the interventional radiology by Dr. Rekha, we hope to get more insights into neuroimaging in the keynote address. So I invite Dr. Bijoy Thomas, Professor, Department of Imaging Sciences in Sri Chitra Tirunal Institute of Medical Sciences and Technology. Dr. Bijoy has more than 200 international publications, 8 book chapters, and 2 patents to his credit. He has received numerous national and international awards and has secured a place in Stanford's top 2% global scientists. His area of interest is advanced neuroimaging. So over to you, Dr. Bijoy.
Thank you, Ksos and Dr. Bindu, for this invitation. I have the maximum time in this session, but 15 minutes is not sufficient to see everything in neuroophthalmology as far as imaging is concerned. So we will stick to 2 things. One is vision loss as well as ophthalmoplegia. So these are my disclosures, and also disclaimer that it's not a complete review. So we will see the first case. We will see cases. So this is a 53-year-old female presenting with acute vision loss on the left side. And you can see this is a T2 weighted scan where that the whatever is inflamed or a fluid will be bright. You can see there is some collection here on the left eye at the choroidal subretinal level, and also in contrast, when you give contrast, you can see that it is actually enhancing. While we are pondering the diagnosis, we will see another case. This is a case, middle-aged female came to us with operated twice for retinal angiomas. It's an old case. I don't think for retinal angiomas anybody will do surgery nowadays. Now she has actually come with a complete vision loss with the thysis bulbae on the right side. Again, how you actually image these, we will discuss at the end of the talk. So we move on to the third case. This is a middle-aged female with a visual blurring and headache. So whenever a patient comes with a acute onset or a relative acute onset visual blurring and headache, we can actually go directly for an MRI because that is the gold standard. Again, one thing I would like to highlight is that there is a tendency that to do initially a CT scan followed by an MRI if needed, and in the era of very reduced affordable cost of MRI, I think there is no role for CT scans except in trauma, or when you are actually there is a contraindication for MRI, or when there is we are suspecting an intraocular or intraorbital or intracranial foreign body. So you have to directly go for an MRI, and the CT most of the time it is only adding to radiation to the lens as well as the brain. Especially in children, you should avoid this, and probably getting future patients for yourself by inducing radiation-induced cataract as well. So this is a case when you see first itself, you can see the perioptic nerve sheath fluid is actually prominent, and also there is a horizontal buckling of the optic nerve. If you are very careful, you can see there is a posterior scleral flattening, and which you have already diagnosed this with the optic nerve, the fundus examination as a raised ICP features. Again, for us, we can't actually see through an indirect ophthalmoscope. What we can see is actually the globe as such. You can see there is a posterior scleral flattening, and again, if you do the contrast, you can see that the optic nerve head is actually bulging in, and it's also showing enhancement. So this is the optic nerve on the horizontal, the coronal section, that is from superior to inferior. If you cut that, what you call that equivalent of an AP section, what we call as a coronal section, you can see the optic nerve fluid is, there is a significant perioptic nerve CSF fluid there, and it is prominent. We will discuss about the dimensions later. And again, you have to carefully look at the sagittal images. You can see in addition to the horizontal buckling, there is also a vertical buckling. So, and if you see this, you have to immediately do a venography and see that the left transverse sinus is relatively hypoplastic, and there is relative narrowing of the transverse sigmoid junction, and the right transverse sigmoid, the distal transverse sigmoid junction also there is narrowing. So this is a case of raised intracranial pressure, idiopathic intracranial hypertension. And when you see this, what next is actually immediately you will actually put the patient on Diamox. That is a good thing to prevent any visual loss, because they can go for a very early visual loss if not treated properly. And one of the newer treatments is actually to measure the pressure gradient across, and if it is there are more than 10 millimeters of pressure gradient, 10 millimeters of water pressure gradient, and you can actually stent this, and the patient can have a significantly reduced intracranial pressure. So this is one of the things. But venous stenting is also not a very easy thing to do, because the antiplatelets may not work as well as in the intra-arterial system. But there are many cases where the stenting, the dual antiplatelets are treated for 6 months and followed by single antiplatelet. Patient will have a very good prognosis. So another very interesting thing is that as soon as you see this on an MRI, you will not go and do stenting, because raised ICP itself can produce a narrowing, especially the posterior part of the superior sagittal sinus, side to side flattening, as well as narrowing here. So you have to see that whether this is a physiological narrowing, or it's actually, this narrowing is actually whether the chicken or egg situation. So you have to make the pressure measurement through the transvenous microcatheter, and then only you can think of. Otherwise, the treatment is actually doing a CSF shunting, either thecoperitoneal shunting, as well as continuing with the medical management. So we know that the optic nerve, I don't have to teach you that the parts of the optic nerve, and this is where we are actually looking at when the patient comes with vision loss. We talked about this. Most of the adult patients after the age of 2.5 years, the optic nerve size may be relatively constant. The total diameter of the optic nerve is around the maximum 5.5 millimeters, and the optic nerve, including the sheath, and the optic nerve as such will be maximum 3 millimeters. So in Indian population, we have found that around 4.5 and 2.5 to 3 will be the actual diameters. And intracranial hypotension, you can see the optic nerve fluid is actually getting drained out, and you can see it is not there, whereas in raised intracranial pressure, you can see that this fluid, perioptic nerve fluid, is actually increasing. So there are various causes of optic neuritis. Again, I wanted to highlight this because this is not the way the neurologists and the ophthalmologists, neurophthalmologists manage these cases may be slightly different. So the evaluation algorithm, as soon as you see the optic neuritis, when the patient presents with the visual loss, with the difficulty, painful movement of the eye or a color vision loss, you will start actually doing this fundus examination, your optical coherence tomography, and you start the IV methylprednisolone. So that is not the way actually it should be done as far as the complete evaluation is concerned. Because optic neuritis is a medical emergency, and immediate blood investigations have to be sent, including the NMO-MOG antibodies as well as the other antibodies, which if it is feasible, and also the routine blood investigations. Immediately after that, an MRI has to be done. An MRI has to do not only the orbit but also the brain as well as the spinal cord. And we have seen that the recurring optic neuritis, most of the time you have to prevent that recurrence. That is why we are actually making a difference, because with every optic neuritis, the vision is actually deteriorating and it may not come back to the normal. And after MRI only you should do an LP, and you have to make sure that there is no raised ICP which is causing this. Secondly, after LP, if you do MRI, there will be significant congestion, and it can, because of the intracranial hypertension which is produced by even removal of even 10 ml of CSF, and which will actually confound your diagnosis of contrast enhancement. After that, you can start your method prednisolone. So it has to be done on an emergent basis, and all these things should be done. And why we should do an MRI of the brain in the first instance itself, because you can see sometimes Dawson's fingers, sometimes there can be, patient may be completely clinically asymptomatic for this neurological evaluation is concerned, but that is called the clinically isolated syndrome, except for that optic neuritis. But you can see that there can be a radiological isolated syndrome also, and then when you can see that these radiological findings, and then you can have no corresponding clinical features. And with the 2017 and the latest very recent the upgrades of MR classification, MR is actually, the MS classification, MR is actually coming to the forefront. If you have more than one lesion in the supratentorial, one in the infratentorial with the myelin the OCB is positive in the CSF, that itself is diagnostic of MS. Why we want to diagnose in the first instance itself, and this is a very graphical representation of where MS is actually producing these abnormalities. Mostly it starts in the one eye, and it will be more in the anterior part of the optic nerve. And you can see in the spinal cord also, you have to very carefully see very short segment spinal cord involvement, and also there can be peripheral lesions which are very small, which are eccentrically located, and the callosocceptal margin may be involved. This is called the dot dash sign, or the Morse code sign, and these are very subtle things, and if you don't do a very high resolution scan, you will miss it. And also you can see the Dawson's fingers. So why it is very important that you can actually start with the present classification of the McDonald's criteria with MRI as well as the clinical as well as CSF examination, and you can start a disease modifying agent. Now there are disease modifying agents like the newer monoclonal antibodies, whereas the patient's outcome can be much significantly better rather than treating them again and again with steroids every 6 months. So this is the spinal cord involvement. So the first instance is the short segment, less than 2.5 vertebral body segment cord involvement, and these are really important, and this is how you can actually make a difference. Why? I know previous speakers have actually highlighted the neuromyelitis optica as well as MOGAD, and this is a very severe demyelination, which is a necrotizing demyelination. It has to be very aggressively treated, not only with steroids, also with the plasma exchange and IVIG most of the time, and also very aggressive supplementary treatment should be done. We can see that the circumventricular organ will be involved, the periaqueductal regions. If you are doing a routine imaging with the 10 millimeter sections, you are going to miss this, and usually there may not be much of a cortical or subcortical involvement. It can be atypical ventricular involvement, not typical Dawson's fingers, and also you can see very long segment cord involvement. Here bilateral optic nerve as well as the chiasm can be involved, and it will produce, it can even present with the persistent vomiting, and because it is involving the area prostrema the regions, you can see this. In this case, you can see again, you have to very carefully look at the FLAIR images, these areas, the area prostrema, that's why the patient is having a recurrent vomiting or sometimes intractable hiccups or cough. And this is how it looks like. It is a long segment involvement, and another reason why we should do not directly start steroids without an MRI is because some of the LETM, the longitudinal extensive transverse myelitis cases, may be due to a dural fistula. If you give a single dose of steroids, they are not going to improve even with the embolization therapy in the rest of their life. So that usually will not present luckily with optic neuritis. So most of the time it will present to a neurologist or a neurosurgeon. Here again, the circumventricular organs are involved, long segment is involved. Very aggressive treatment is needed, because if they recur, it will be usually very devastating. And also presence with the bright spotty lesion. I will not go into the entire neuro radiology of this. Again, you can see that the perioptic nerve in this
this particular case, there is inflammation in the perioptic nerve lesion. You can see this fat stranding of the optic, the orbital fat. This is what we call the dirty fat sign. And you can see in this case, in these cases, conus may be more involved. If you see this dirty fat sign, it is more suggestive of a Mogard. So there are various ways in which you can actually, with imaging itself, we can actually differentiate. This is a 17-year-old patient presented with the vision loss in the right eye followed by the left eye. Again, you can see the right optic nerve is thickened. Initially, it was enhancing. It was diagnosed in optic neuritis. Later, you can see we have to do a spectroscopy also. You see the lactate there, and the patient, there was a very sudden, rapid progression of the vision loss, and this turned out to be Leber's optic neuropathy, and sometimes Leber's usually present with optic atrophy, but in the acute phases, they can even present as an optic neuritis-like presentation, even with a contrast enhancement. Now the chiasm tracks, because of the lack of time, I will actually quickly go through that. We can also look at all these things. This is a graphical representation of how the optic pathway is running. What we can see that the anterior optic pathways can be diagnosed, been seen very well with the T1 and T2 weighted images, where the optic radiation right from that lateral geniculate body to the Mayer's loop can be seen with newer advanced sequences like SAA, because myelin is showing a susceptibility there. And you can see this even your routine cases, you can see the lateral geniculate body, but how many of us are actually giving a look into these areas where we are actually having an acute vision loss. So coming to that pituitary lesions, or this is a Rathke's cleft cyst, and which is producing the chiasm in the center. The classical teaching is that it produces bitemporal hemianopia, and we have never seen a single case where it's true bitemporal, because it will be always asymmetric. This is what happens. Normally the pituitary gland can be 88% of the time it is centrally located, the chiasm, but there can be prefixed or a postfixed chiasm. So you are exact because the pituitary lesions don't read in ophthalmology, neuroophthalmology textbooks. This is what happens, and your diagnosis most of the time will not be very accurate as far as bitemporal hemianopia is concerned. Then we have to do epilepsy surgeries, and we have to make sure that they will not produce, the surgery will not produce the after anterior temporal lobectomy, should not produce a quadrant anopia. This is what the Mayer's loop is there. This is how that resection will produce a superior quadrant anopia. So we have to do advanced sequences like diffusion tensor imaging, can map this from the lateral geniculate body to the Mayer's loop to the optic radiation, and we can actually show the surgeon that this is, we have actually published some time back. Now with the SWA sequence, which I have shown that myelin is producing susceptibility, you can actually track the tract, and the surgeon can limit anterior to this. So the cortical lesions, cortical blindness, we can do functional imaging, especially mapping these visual areas, visual association areas. They are mostly used for only research, and this is the last few cases. This is a 56-year-old male, diabetic hypertensive with a sudden third nerve palsy. You can see if you are not careful and do thin sections, you can miss this, and diffusion, you can see the third nerve nucleus is actually infarcted. So the perforators infarctions can happen even in the nucleus, and this is a nuclear involvement. More commonly, you will see that the third nerve palsy may be due to mechanical compression or a demyelination of the third nerve itself. This is actually the third nerve, and in this case, the patient presents with a partial third nerve palsy. You can see this is the posterior communicating artery, and the posterior communicating artery is actually shifting the third nerve and partially compressing it. That's why the patient presents with the partial third nerve palsy. Compared to this case, presented with the complete third nerve palsy, which is due to mechanical compression, unlike in diabetes, and you can see the pupil is involved, and this is due to a parapicum aneurysm, which is again compressing the third nerve. This is a very interesting case. One auto driver, I don't know whether I can take one more minute. So one auto driver, the auto rickshaws, if you are not careful, auto rickshaws have projecting needles all over. You can see they have a very sharp objects as a wheel cup. And also in this particular case, auto driver was actually cleaning his auto in the morning, and there was a very sharp needle-like metallic thing from the rear view mirror. He was actually cleaning, and he suddenly got up and hit something, and there was a little bit of blood. Immediately noticed that there was a drooping of eye, and when he was actually brought to ophthalmology and he was a third nerve palsy, he was sent to us for imaging. after CT scan, we saw he thought that initially it was considered as a blunt injury with some injury there, but what is actually gone? We have after doing the CT, we found that there was a defect in the squamous temporal bone. When we have done the MRI, after ruling out that there was no metallic objects, there was a very sharp needle which has actually gone inside and came back when the patient was flipping. So this was not it was a sharp injury which has actually gone and actually hit. This is where the third nerve is in the wall of the superior part of the cavernous sinus. It has actually gone and hit that the third nerve and came back. This is the needle track, and the patient didn't know that it was actually head injury. So luckily it has actually not injured the cavernous carotid artery and not produced a pseudo aneurysm or a CCF. And this is the thyroid ophthalmopathy. For the benefit of the postgraduates, this the mnemonics is that inferior rectus, medial rectus and superior rectus, the way in which actually it is involved. The inferior rectus will be the maximum involved, so the mnemonic is I am slow, and sometimes superior rectus can also be first involved, so then it's called sim slow. And this is carotid cavernous fistula. We have actually seen the different subtypes, and we can do very easily, you can diagnose with an arterialization of the superior ophthalmic vein, and we can do the embolization as previously mentioned. This is a very gratifying thing for interventional radiologists. Only interventional neuroradiologists can treat this. There's no surgery can be done, no medical treatment can cure the patient. So this is a last case. The 40-year-old doctor presented with altered sensorium and complained of something crawling inside her eye. She was also, because she had an alternate sensorium, this was an old case. You can see that there was some hyperintensity in the cerebellum. This is when, this was in 2007, when we had the SWA sequence as a new sequence, so we tried to do this. You can see some hypo-intensities there, then very subtle enhancement, we didn't know what it is. Again, if you see that there are hypo-intensities there, susceptibility blooming there, and this is what she, after 2 weeks, there is further increase. Because she was seeing this, there was the vitrectomy was done. This is what they removed, and this is, you can see, this was a case of angiostrangulus condensis infection. What is so in the brain is actually lava migration tracts. So this was luckily diagnosed early, and when you are actually, this is not commonly reported from Kerala, but there are reports from Kottayam, and you can see that especially when you are actually, when these snails are infesting your horticulture garden, you should not actually eat the raw vegetables. So that's what this patient did. And then coming back to our last, the first few cases, this case had a enhancing in the choroid, and this turned out to be a metastasis. You can see a large mass in the breast. So usually we don't see diagnosed breast carcinoma like this. Will be very, very subtle, and this case even when there are axillary lymph nodes and mediastinal lymph nodes and metastasis. So this is you have to be very aware that when you see these cases, it has to be appropriately imaged. So melanoma metastasis, you can see that can be diagnosed even MRI. T1 it is bright, and in T2 and susceptibility will bloom. And the second operated retinal angioma case, this when we did the spine imaging, you can see multiple hemangiomas, and this is a von Hippel-Lindau syndrome. You have to also screen the abdomen for pancreatic liver cysts and vessel renal carcinomas. To conclude, clinical diagnosis is the key, and I think you should do appropriate imaging, complete imaging, so that we can actually help the patient, especially for acute optic neuritis. You should not treat it as an isolated syndrome, isolated disease, but it can be a real syndrome. It can be treated, and you can prevent that second recurrence. Thank you very much.